This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2019, all rights reserved. My name is Shauna Strickland, and I am your moderator today. I am a registered respiratory therapist, asthma educator, and associate executive director at the AARC. I welcome you to today's presentation, Recognizing and Correcting Patient-Ventilator Asynchrony. Upon completion of this AARC webcast, participants will be able to identify various types of patient-ventilator asynchrony in the VC-AC mode of ventilation using widely available scalar waveforms, discuss the physiologic causes and clinical implications of various forms of uncorrected patient-ventilator asynchrony, and recommend potential ventilator parameter changes to correct recognized asynchronies. I am pleased to welcome Mr. Eric Kriner. Eric is a registered respiratory therapist and the pulmonary critical care clinical specialist at MedStar Washington Hospital Center in Washington, D.C. He provides mechanical ventilation education for a variety of healthcare providers and is a co-author and faculty for a lecture and simulation curriculum for advanced mechanical ventilation program for the D.C. Maryland area pulmonary critical care fellowships. Eric discloses relationships with Medtronic and Ingmar Medical. I disclose that I am a paid employee of the AARC. Brand names of products and or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. Eric, welcome to the program.
Thank you. Thank you for having me. So we're going to talk about patient ventilator asynchrony, and at the very beginning I was discussing the approach in kind of an organized fashion and how to interpret what you're seeing. And I made the reference about how you learn to read chest x-rays, essentially, and you did so in an organized fashion. You either interpret the x-ray from the outside in or the inside out. And you do this so you don't miss the details, because what kind of often happens is that your eyes are drawn to the big white shiny thing on an x-ray. And if you stop there, you're likely to miss the details that are overlooked unless you do your interpretation or your assessment in a detailed and organized fashion. So that was the analogy that I made, and how you can approach assessing patient ventilator asynchrony. And in so, I think maybe perhaps one way to do it is to just go through each part of the breath, essentially. And so the first part of the breath is called the trigger. The trigger is how you turn the breath on, or how the breath is initiated. And so the inspiratory valve opens, and once the inspiratory valve opens, now inspiratory flow is delivered to the patient. We'll call this portion of inspiration here the breath delivery portion. It can be a little clunky, because I think if you were to look this portion of the breath up in a textbook, it would be referred to as the limit. However, this is the breath delivery portion. This is what's happening when gas is being delivered from the patient or from the ventilator to the patient. So this is the inspiratory flow portion of the breath. And once the ventilator is initiated, or inspiration is initiated, the inspiratory valve opens, the breath is delivered to the patient, and then the breath has to end, and that is called the cycle. So there are really three distinct parts of inspiration alone: turning it on, or the trigger, getting the breath there, or the breath delivery, and then turning it off, or the cycle. And so once the breath turns off, it now goes into exhalation. And there are four distinct parts of every single breath, whether it's mandatory or spontaneous, and that leads you to an organized way to assess patient ventilator asynchrony, because things can go wrong with each portion of that breath. And there is a trigger asynchrony, an inspiratory asynchrony, cycle asynchrony, and expiratory asynchrony. And then as you start to unwrap this and consider all of that, there are those trigger inspiratory cycle and expiratory asynchronies across each mode of ventilation and those control variables. So there's a trigger inspiratory cycle in VC, PC, and volume targeted pressure control. And as well, if you consider the spontaneous modes, there's those same asynchronies in PS and volume targeted pressure support. So how this unwraps for you is that this is essentially a huge can of worms, or big package to unwrap, whatever euphemism you want to use here. And it takes a lot of time and dedication, and certainly we're not going to be able to get through all of these within the next hour, 43 minutes or so here. So we're going to focus on VCAC, and we will go ahead and get right started since we lost a little bit of time. We're going to focus right away on trigger asynchrony. There are two types of trigger asynchrony. The first type is ineffective trigger. The second type is an auto trigger. So we will focus right now on ineffective triggers. An ineffective trigger is when the patient goes to initiate an inspiratory effort. However, the ventilator on the other side doesn't, for whatever reason, see that initiation. So it doesn't deliver the breath to the patient. And therefore, there's a wasted effort on the patient's behalf. You can often hear this called an ineffective effort, an untriggered breath. I'll refer to it here as ineffective efforts, though. What you see on the screen there on the right-hand side is a screenshot of a patient with ineffective efforts. I'm going to blow that up for you here and specifically focus on the pressure time and the flow time scaler. On the top is the pressure time, and on the bottom is the flow time scaler. These are widely available to everybody. There's no special equipment needed, such as esophageal manometry or diaphragmatic EMG. So this is available to all of us here. And what we're looking at in assessing whether this patient has ineffective efforts and thinking about logistically what's happening is that the patient begins their inspiratory effort, and in so doing, they drop their pleural pressure and they decrease interthoracic pressure, and therefore the airway pressure starts to go down. And you can see that with the red arrow that I have depicted there, that there is a decrease in the airway pressure. I will caution here, though, is that this can be a little tricky sometimes because of the vertical axis and how essentially zoomed in you are on that. I have this vertical axis pretty tight so that I can show you this. However, sometimes, depending on how far out you are or how zoomed out you are, that line will be pretty flat and you can't depict whether there's a decrease in airway pressure. So that's my only cautionary tale about just using that airway pressure. However, on the other side of things, when that breath isn't delivered, there is this kind of distinct change in the expiratory flow, which I would say is probably a little bit more sensitive in that. The expiratory flow, as it approaches the baseline, just below where that oval is, I'm not going to be able to have a cursor, but just below where that oval is, all of a sudden takes a sharp turn towards the inspiratory scale. And what's missing there as the expiratory flow is sitting on the baseline is the delivery of the breath. So that's the missing portion there. And what you see is this reacceleration of expiratory flow. And this is the telltale sign that I would say is all of this information that's being given to you on the expiratory flow. I often like to say is that if you ever want to really, really understand what's happening with your patient, look at the expiratory flow, because you don't control that. That is completely passive, and that's when your patient is essentially telling you what's going on with them. They're talking to you at that point. You control much of the inspiratory breath across all the modes. So in this expiratory flow, we see a lot of information coming to us in that there's a sharp rise in expiratory flow going towards the inspiratory scale. It sits across the baseline, and then there is this reacceleration. So if you can imagine here, the patient expands their thoracic cage to try to take a breath. So the inspiratory flow is coming towards the the inspiratory portion of that flow time scalar. The ventilator doesn't recognize that effort, so therefore doesn't deliver a breath. And the patient at that point kind of gets done with that pseudo-inspiration, and we'll call it a pseudo-inspiration because they weren't delivered a breath, and therefore at some point gets tired of doing that and goes into that expiratory phase. And when they do that, they decrease their thoracic cage size, the pleural pressure goes up, and what you see is this little reacceleration of expiratory flow, denoted by that arrow down on the flow time scalar. And I would say that those reacceleration in expiratory flow is your telltale sign, more so than the pressure time that I have depicted up at the top. Here I have a clean screenshot of what you would typically see, and again, what you can depict on the expiratory flow is that there's a reacceleration of flow going towards the inspiratory portion of that flow time scalar. The patient is not rewarded with a breath, and then it reaccelerates into exhalation again. And so that is your telltale sign. Notice here on the pressure time is that decrease in pressure time isn't as sensitive. You can see it. There's a slight decrease in airway pressure, but it could leave you questioning without the expiratory flow portion of that. The implications. So I would say this, is that if there are ineffective efforts, what you have here is on the patient's behalf an increased work of breathing, essentially. They're employing their inspiratory muscles to try to trigger a breath, and they are not being rewarded with said breath. So it's a wasted effort, and there's a significant increase in work of breathing on the patient's behalf. There's also what you have to, I think, appreciate is this phenomena of breathlessness on behalf of the patient. They're trying to take a breath. Their brain is telling them they're trying to take a breath. Everything about them is trying to do this. However, the machine isn't delivering a breath to them. The patient will tell you at this point a lot of times that they're fanning themselves, I'm not getting any air, and a lot of times they're exactly right. They're self-diagnosing almost. And what this kind of unravels here, or how this unravels, is because they feel breathless, they become more anxious and more agitated, and they become more difficult to manage at that point. So those are really the clinical implications of an ineffective trigger. How to correct this? So I would say this, is that nearly in every single instance of an ineffective effort, it is going to come in the face of auto-PEEP. I will point out the other type of or the other reason why there's an ineffective effort. But for the vast majority of patients, ineffective efforts are going to occur in the face of auto-PEEP. And here's why, and here's what's going on. If your PEEP is set on 5, which I have depicted there, and we'll say here for our purposes of explanation that the pressure, we are a pressure triggering mechanism and it's set at 2. And so what ends up occurring is that the ventilator sets up in its head, essentially, a trigger threshold, which is that green dotted line there. So anytime, for whatever reason, that the airway pressure goes to 3, the ventilator is monitoring and sensing that drop in airway pressure to 3, that trigger threshold, that is mathematically set up between the two settings there. And when it sees 3, it opens its inspiratory valve. However, what occurs in the face of auto-PEEP is that the ventilator doesn't know about that extra auto-PEEP or that extra level of PEEP. It doesn't know the alveolar pressure at the end of exhalation. It knows the airway pressure, but it doesn't know the alveolar pressure. And so that goes unrecognized by the patient. However, it's functional, essentially, because the patient still has to drop the alveolar pressure down, the airway pressure down to that trigger threshold. So in this scenario, what I have made up is that the total PEEP is 10, and mathematically based on a PEEP of 5 and a pressure of 2, the trigger threshold remains at 3. The trigger threshold does not walk the pressure scale up with the auto-PEEP. And so what ends up occurring is that instead of a functional drop in airway pressure of 2, what ends up having to happen is that the patient has to drop pressure through the auto-PEEP, 7 centimeters of water down to the trigger threshold of 3. And that can be entirely difficult for some patients. And the reason why, though there's a drop in airway pressure, which sometimes you can see, and the patient is making an effort, that the ventilator doesn't recognize that because they were not able to drop airway pressure all the way through down to the trigger threshold. You may be saying, well, that's good. My patients never will have ineffective efforts because I use the flow trigger. And I usually use a pressure trigger just to set up and kind of explain what's going on. However, if you were thinking I'm using a flow trigger, so this isn't applicable to me, I think you should reconsider how this is working here because it's still entirely applicable to you. Because what ends up happening is that if there is no change in airway pressure, which is what we're kind of talking about here, there's no change in airway pressure, then there will be no change in flow, essentially. So even though you're flow triggered, there will be no decrease in the bias flow if there's no change in airway pressure. And therefore, the ventilator won't recognize that change in flow, and it won't reach the flow triggering threshold, and therefore won't deliver the breath to the patient. I would say this, we can demonstrate this. If you would take a really big deep breath in, and as big as you can, and then you were to hold that breath, I would say that you are now a hyperinflated, air-trapping, asthmatic COPD patient. And don't exhale, but if you were to try to inhale from that point, what you would find is that there would be no change in pressure and no change in flow. And so that's kind of one way you can almost test that theory on yourself. Take a big deep breath, hold it, and then try to take another breath on top of that. And what you'll find is that even if you're flow triggered, there's no change in flow there. So those ineffective efforts are typically due to the development of auto-PEEP. So to correct them, you have to correct the auto-PEEP. I would consider auto-PEEP a form of expiratory dysynchrony. So at this point, I'm going to punt that to the end when we talk about expiratory asynchrony, and we'll look at how to fix that then and there. All right. That other group of patients that their ineffective efforts aren't due to air trapping or auto-PEEP, that is typically just due to more or less an inappropriate trigger setting in pressure versus flow. So what I have here for you is a screenshot. The patient is on a pressure triggering mechanism. The pressure sensitivity is 2, and you can see the characteristic reacceleration of expiratory flow almost every other breath there. So what would be missed breath number 2, missed breath number 4, missed breath number 6. And so that's what you look at there. However, if I just change this to a flow triggering mechanism, which is typically a little bit more sensitive to the patient, you can now see the appearance of all the breaths across there. And so most times ineffective trigger is due to air trapping. The other little teeny tiny portion of patients that have ineffective efforts are just due to you have a pressure trigger versus a flow trigger. Here's where I want to kind of make a real distinction in two different things that are going on. The first is an ineffective trigger, and the second is an active exhalation. So up at the top here, I have what would be an active exhalation. Down at the bottom, I have what would be an ineffective trigger. And from your eyeballs, just looking at them, you would say, they look pretty much the same, and they would be quite often, in my experience, diagnosed both as ineffective trigger. However, what I want to show you is a real distinction between the two of them. So on the left here, I have active exhalation, and what I'm going to do is just superimpose what a normal expiratory flow would look like. And as I draw that as it reapproaches baseline, you can see that the departure of expiratory flow is more positive. It doesn't go towards the inspiratory portion of the flow time scalar. It's actually going more towards the expiratory flow time scale portion of the flow time scalar. So in this case, this isn't an ineffective trigger. What it is an active exhalation because the patient is pushing gas out, not trying to pull a breath in. So there's a distinction there versus the one on the right, which I've superimposed what the normal expiratory flow would look like. And you can see that expiratory flow goes in a different direction than what we had just previously spoken about. That departure from normal goes towards the inspiratory portion of the flow time scalar. So you have two different directions of that expiratory flow. So what I would caution you is don't just look for the hump in the expiratory flow. I think what you have to really examine is which way the expiratory flow is departing from normal. Is it going more towards the inspiratory portion of the flow time scale, or is it going more towards the expiratory portion? Because there are two different things here. And so that's the distinction between the two of them. All right? So that's ineffective trigger. Quickly into auto trigger. We'll kind of go through this, in relative speed so that we can get to the rest of them. Auto trigger is the exact opposite of ineffective trigger, essentially. Auto trigger is when the ventilator is coming on unintentionally without the patient making that effort to take the breath. So, exactly the opposite. I think recognition is, first and foremost, has to be a high degree of clinical suspicion on your part. We'll take the example of a patient that is brain dead, and for whatever reason, the ventilator is delivering more breaths than the set respiratory rate. So you have a high degree of clinical suspicion. They're very, very heavily sedated, yet they're still triggering above the ventilator. So that's what I mean by a high degree of clinical suspicion. And then with that in mind, what you can sometimes pick out here is that on the pressure time and flow time scaler that I have pictured, you can see that there's this rhythmic increase and decrease in both the pressure and that expiratory flow there. This particular patient, those changes in the pressure time and the flow time scaler, those are caused by cardiac oscillation in this particular patient. And what those changes in systolic and diastolic pressure were doing were causing changes in the interthoracic pressure as well that were significant enough that the ventilator was sensing them, and in so doing, it was actually turning on inadvertently. So the patient was making no effort to breathe. Essentially, the cardiac oscillation was turning on inspiration. Auto trigger can also be caused by water in the circuit, causing periodic changes in flow and pressure that the ventilator sees and misinterprets as a patient trying to take a breath, or simply a leak in the system. Because remember, it's the trigger threshold that the ventilator is monitoring. So whatever decreases that pressure or changes that pressure down to the trigger threshold, the ventilator doesn't necessarily interpret what did it. It just asks if it reached that trigger threshold. And if it does, it turns on, intentionally or unintentionally in this case. To correct this, if confirmed, once you've absolutely confirmed that the patient is not making a respiratory effort, and we have, in this case, a cardiac oscillation, I think this case, you make the trigger mechanism more difficult in relation to the patient, more difficult for them to trigger on. If it's due to a leak, clearly you would fix the leak. If it's due to water or fluid, you would clear the water or fluid from the circuit. So you would correct the causative agent of your auto trigger there. Let's see. We will continue on here. So I have ineffective efforts. This is kind of a summary slide. Ineffective efforts on the top. The telltale sign again is your reacceleration of expiratory flow. The expiratory flow gets faster there. And auto trigger denoted by the rhythmic increases and decreases in pressure as well as flow, and that high degree of clinical suspicion on your part. We are going to advance here into the next portion of the breath. So once the breath turns on, triggers, the next portion is the inspiratory flow or the breath delivery portion. There's two types of inspiratory dysynchrony. The first type is an inadequate flow, the second type being excessive flow. How to recognize inadequate flow? I think you first have to start with, in anything here, what normal looks like. So the normal pressure time scaler with a decelerating flow should have an exponential rise as it goes towards its peak, nearly square, but kind of rounded off there on the left-hand side as it approaches. And this is in a decelerating flow waveform. What I have pictured here for you is an abnormal pressure time scaler, and this patient has an inadequate flow. we will focus and blow up that inadequacy or the abnormality there. On the top, you have what would be normal exponential rise in airway pressure, and down on the bottom, you see that there's a clear departure from normal. There's a drop in airway pressure on the way to the peak. My analogy that I always like to use is this. I have here pictured a Frosty. You can think of any really good thick milkshake, and let's say that instead of a straw for your Frosty, or instead of a spoon, you have a straw. And so you have a straw in the Frosty, and you go to try to take a drink of the Frosty. And you make the same effort that you would to take a breath to drink that Frosty. You make that effort. However, if you can picture this, you wouldn't be delivered the Frosty. It would not come up the straw. And your first knee-jerk reaction is to pull even harder, by the way. So we'll kind of put that in our back pocket for a little later and refer back to that. But you try to pull the milkshake or the Frosty through the straw, and so you essentially have an inspiratory Frosty demand. You're pulling as hard as you can at 90 liters a minute. However, the Frosty is only coming up the straw at 30 liters a minute. And if you can picture, again, and put yourself in this scenario and ask, well, what would happen to the straw as you're trying to drink the milkshake through the straw? And that answer would be that the straw collapses because of a negative pressure. And that, if you were to draw it on a pressure time scaler, is exactly what this would look like down here on the ventilator scaler. So this patient, that's your analogy, is that inadequate flow is like trying to drink a really thick milkshake through a straw. I'm going to apply the equation of motion here. Analogies are really good because those are kind of what sticks with you. So this patient is sucking Frosties, trying to drink milkshakes. They're not getting it. However, the science or the physics behind it is interpreted through the equation of motion, essentially. So I have the equation of motion drawn out here. Airway pressure equals flow times resistance plus volume over compliance plus PEEP. And lend me this here as we go through. That resistance, once the breath starts, doesn't change. So we'll kind of put this box around this. And in a test lung, essentially, or on a patient that isn't active, the compliance, if the PEEP is appropriately set, that is a clear distinction that I want to make, the compliance doesn't change, all right, once the breath starts, provided we have the right amount of PEEP. The flow in VCAC and the volume in VCAC are set, as well as the PEEP, so those do not change and are constant, and therefore the variable in this particular mode is airway pressure. If I consider what happens when a patient is involved, I have to drop them into this equation somewhere, essentially. And the patient is going to be represented here as PMUS. So I'm going to put this on the left side of the equation, essentially, with the pressure. So airway pressure plus PMUS equals flow times resistance plus volume over compliance plus PEEP. And in our situation here, the patient is pulling in very hard, vigorously. And so the PMUS is going up. However, the flow and the volume are set and constant and therefore don't change. I've grayed out the resistance and compliance and PEEP here. They do not change either. So if the PMUS is going up on the left-hand side of the equation, nothing on the right-hand side of the equation is changing at all. And you ask yourself, well, what has to happen to airway pressure at this point? That answer would be that the airway pressure has to go down so that the left side of the equation of motion continues to be equal to the right side of the equation of motion. And it goes down by the exact same amount that the PMUS goes up, essentially. And that phenomena is reflected to you on your airway pressure graphic. That's why the airway pressure goes down, because PMUS goes up in this particular scenario. So that's the physics, essentially, behind that. The implication of inadequate flow, I would say this, is an increased work of breathing on the patient's behalf. What I have here drawn for you is a reference, essentially. So I've drawn what a normal, in red, what a normal pressure time scaler would look like over top of our abnormal waveform. And what you can see if I do that is that there's a clear departure from normal. The airway pressure is definitely way lower than what it should be, essentially. And the area underneath of that curve, if you did the calculus, would be the would-be worker breathing on the patient's behalf, because the only reason why airway pressure goes down at that particular point is because PMUS is going up, and that, therefore, is an increased worker breathing on the patient's behalf. The other phenomenon that is accompanied with this is, again, this feeling of breathlessness and agitation and anxiety, because the patient isn't receiving the breath that they're actually demanding, right? And remember what happened when you went to drink your Frosty. You tried to pull it through, and it didn't happen, and your next immediate response was to pull harder. So we're not talking about Frosties and milkshakes. We're actually talking about a breath being delivered to a patient. And it's not being delivered at the flow that they want it. And so therefore, that's why the patient feels the way that they do. And I think if we're honest with each other, how we correct this a lot of the time isn't based on the ventilator, because the patient is anxious and agitated and all over the place because they feel like they can't breathe. And if we're honest, that patient gets sedation. And this isn't a patient problem. This is an us problem. This is a you problem that you have to fix. And we, unfortunately, use other means to fix this. We fix the patient instead of the machine. So to fix this on the machine, you would simply increase the flow. And here's the thing that I want to make note here, is that I can't tell you how much to increase the flow. I have no idea how much the patient would need. You need to increase the flow, in this case, from 70 liters a minute to 80 liters a minute. And the key is you have to increase the flow until you get back to normal, essentially. The airway pressure returns to its normal form. If you happen to use a ventilator platform instead of a set flow in VCAC, it has a set TI. This is okay. You just decrease the TI on that particular platform. And if you decrease the time and try to get the same volume in a shorter period of time, the flow increases. So that's how you would correct that on that particular platform. So two types of inspiratory dysynchrony. One is inadequate flow. The other one is excessive flow, which is essentially the exact opposite. It takes on a different appearance. Clearly, it's not inadequate flow, and it doesn't have that drop in airway pressure. We're talking about excessive flow, and so instead of a drop in airway pressure, you actually have a spike in airway pressure on the left-hand side. To correct this, you would simply decrease the flow. I'll make some commentary here in that this, I feel like, is one that we typically have to let go sometimes, because to fix this, you have to decrease the flow. Therefore, the inspiratory time would lengthen, the expiratory time would then shorten, and quite often you don't have the luxury of that to shorten the expiratory time, because the patient needs that time to adequately fully exhale. So this is one that often you kind of have to reassess and think about how you're going to fix this, because by lengthening I time and shortening E time, that may not be a viable option in your particular patient. We're going to, this is a review slide here, summary slide essentially, on the top of inadequate flow, that decrease in airway pressure. On the bottom, excessive flow, the spike in airway pressure. So we're talking about the beginning of the breath, or that front of the breath. This is where that abnormality is. I'm going to now go to the end of the breath, or the cycle, how it is terminated. There are two different types of cycle dysynchrony. There's a premature cycle and a delayed cycle. First, we're going to focus on a premature cycle. So premature cycle is often called double triggering. I don't love that word, double trigger, because what I find a lot clinically is that if we call it a double trigger, people will try to fix it by fixing the trigger, because trigger is in the name. And I think what you have to appreciate is that what is really, really happening in this logistically in the patient-ventilator interaction. So what is occurring here is that the patient's neural inspiratory time is longer than the ventilator's inspiratory time. So the patient's brain is telling them to breathe, and that neural inspiratory time ends up being longer than the ventilator's inspiratory time. And so what occurs in this cartoon as we advance through the slides is that the ventilator delivers a set volume, and because we're in VCAC and volume cycles the breath off, or is what ends inspiration, that's what's occurring here. However, on the patient end of that logistical model is that the patient isn't okay with the ventilator's set inspiratory time. Their brain actually wants something that is longer. So they continue to inspire and expand their thoracic cage. In so doing, they drop the pressure and the flow in the circuit. And if they do this, make this effort long enough and hard enough, what they end up doing is dropping the flow and pressure in the circuit enough that they actually trigger a second breath to be delivered to the patient. So for one inspiratory effort on behalf of the patient, the ventilator is delivering 2 breaths to them. And so this presents a problem. This presents a big asynchrony between the patient and the ventilator, and has, in my view, pretty significant clinical implications. I'm going to point out on the scalar graphics how you can recognize this here. I've blown up this particular 1 breath here, and you can see that there is an inspiratory flow delivered to the patient, and then followed right afterwards there's a second inspiratory flow. So I'm looking at the flow time scalar, and you have this M here, and you also have the same thing up on your pressure time scalar. So thinking about the logistics that we just described, that is what's occurring there. The ventilator will often read double zeros to you, or the exhaled volume reading 0, and that is because if you think here and you look at what is the expiratory volume of that very first breath, you can clearly see in the picture that I have here that the expiratory volume is actually 0. There's nothing wrong with that ventilator telling you that the exhaled volume is 0. The second breath that is delivered, mandatory breath that is delivered to the patient in that one patient effort, is then delivered, and both breaths are exhaled, and what you'll find is that the ventilator will then read a doubled volume to you there. So this is how and what you can look at in terms of trying to diagnose or understand the cycle dysynchrony. I think I would call this severe cycle dysynchrony here. Is what we've been talking about, is that there's 2 breaths delivered to the patient. Again, if you look at the flow time scalar down at the bottom, you can see the first breath delivered, followed immediately without exhalation, that second breath being delivered to the patient. However, I think what you have to contemplate and appreciate is that there's varying degrees of this mismatch between the patient's neural time and the ventilator's inspiratory time. That in so they do not necessarily trigger that second breath. The same problem exists, is that the patient's neural time is longer than the vent's inspiratory time. However, it's not long enough or strong enough to trigger that second breath to come. So we'll call this moderate cycle dysynchrony because of that. They don't get the second breath. However, the mismatch still exists. And what you can see here is that if you look at the flow time scalar down on the bottom there, that there is this clear departure from the normal spike in peak expiratory flow with the exponential flow and decay going towards the baseline. And up on the pressure time scalar, there's a clear departure from normal there as well. We'll look at that in a little bit more detail a couple slides down the line. And then another varying degree is this mild. Again, the same problem is the patient's neural time just isn't quite as long as it was prior to or in our first description, so it doesn't trigger that second breath to come, nor is it as long as this moderate one, because in the moderate one, what you can see is that reacceleration of expiratory flow there, and in the mild, there's just a rounded expiratory flow. So those are the varying degrees, all the same problem, just the patient's neural inspiratory time isn't quite as long. This is all 3 of them lined up for you. And let's talk about the clinical implication of this. The clinical implication is somewhat profound. It's not that breathlessness and the increased work, although bad, both bad. This one takes on a bit more of an urgency and is a bit more serious, especially if your intention therapeutically is to limit the patient's volume in a patient that has ARDS. So if that is the case, in this particular patient, I have them on 6 cc's per kilo. This is what's pictured. So 350 milliliters is 6 cc's per kilo for this patient. However, what you see in the red box there is a severe cycle dysynchrony. And so what ends up occurring is that 6 cc's is indeed delivered with that first breath. However, as described, the patient actually gets 2 mandatory breath deliveries for every 1 effort, and that's what you can see there. So functionally, the patient isn't receiving 6 cc's, they're actually receiving 12 cc's per kilo. And in referencing the ARMA trial, I think we all have gotten to the point where we understand the implications of 6 cc's versus 12 cc's, in that 12 cc's, there was a higher patient or higher mortality in that patient group versus the 6 cc's. So if this is your therapeutic intention to limit volume, you're setting them on 6 cc's per kilo, and you do not recognize or appreciate or fix this particular scenario, you are doing and letting extreme harm come to your patient in the form of an increased mortality. Let's talk about the clinical implication of the moderate or the minimal or mild cycle dysynchrony. Not quite as profound. However, if I were to superimpose again the normal pressure time scaler, you can again see that there's a clear departure from normal. The airway pressure drastically decreases from what it should be there. And again, if you think about what decreases airway pressure, according to that equation of motion, it is an increase in PMUS through that cycle mechanism there. And so, again, the area underneath of that curve is an increased worker breathing on the patient's behalf. So this lends me to, I guess, this question. If you had your patient on VCAC, and this is what they looked like, or you had your patient on VCAC and they had inadequate flow, that's what they looked like. Is this what you would call a resting mode of ventilation? And I think that answer is absolutely no. A resting mode of ventilation is defined by that which alleviates work on the patient's behalf, not necessarily the acronym or the alphabet soup that sits in front of that name of the mode. That's not what defines a resting mode. It's just the alleviation of work. And in this particular patient, there's significant work on the patient's behalf. So, correcting this. So the correcting the cycle dysynchrony, I think you have to be firmly rooted in the fundamental problem, and that is the ventilator's inspiratory time is shorter than the patient's time. To correct this, you have to lengthen the ventilator's inspiratory time. And I'm going to click through here just because I'm peeking at the time down there. To fix this, you have to lengthen the ventilator's inspiratory time. And you have to know your mode here and the nuts and bolts and how it works. To lengthen the ventilator's inspiratory time, if you have a set flow with VCAC, there's 2 options essentially, because you control time with flow and volume. And so if you decrease the flow, you'll lengthen the ventilator's inspiratory time. Or you can increase the volume, and that will lengthen the ventilator's inspiratory time. And your goal is to lengthen the ventilator's inspiratory time to more approximate the patient's neural inspiratory time. Those aren't always viable options, specifically referencing the volume, because if your intention is to volume limit them, as in the patient that we presented earlier, clearly you cannot and should not increase the volume in this particular patient. So I would say your approach there is more so to address the patient's neural inspiratory time, and this is a scenario in which sedation or paralysis is probably appropriate here. So cycle asynchrony, I'm going to click through here really quick just to our summary slide, because I'm probably going to have to cut this off here. Your premature cycle, what you have pictured here is a severe, and there's your moderate, and here is your mild cycle asynchrony. I'll address delayed really quickly. We can think about it essentially just by looking at the summary slide. A delayed cycle is the exact opposite, in that the patient neural inspiratory time is longer than the ventilators. So they are starting their expiratory effort while the ventilator is still in inspiration. And when that occurs, they are exhaling out against the breath coming in, and you see a spike on the end of exhalation there. And that's the difference between the 2 of them. To correct that, you would just shorten the inspiratory time. I think we have about 4 minutes left. I'm going to do this last slide, and then we'll cut it off here, because I've presented 2 different decreases in airway pressure, and I find that they're very confusing. This is up at the top an inadequate flow, and this down at the bottom, what I have pictured for you is a cycle asynchrony. So you have a problem on the front of the breath versus a problem on the back of the breath, both of which decrease airway pressure. And here's what I want you to think about, because what you'll often see is a decrease in airway pressure, but not understand, is it on the front or the back? And if it is a cycle asynchrony, the problem is transitioning from inspiration to exhalation. And if that is the case, your expiratory flow will always be affected. And so, again, if you want to know what's happening, address or look at the expiratory flow. If the problem is on the front of the breath, there's no issue with transitioning between inspiration and exhalation. So there will be normal expiratory flow, and therefore that is an inspiratory dysynchrony. However, if you look down at the bottom, there's abnormal expiratory flow in both of them, telling you that that drop in airway pressure is occurring at the transition from inspiration to exhalation. Therefore, that's a cycle asynchrony. Unfortunately, I'm kind of right up against it. I'm going to go to the very end here. What we didn't get to, because it's so much, is the expiratory dysynchrony or asynchrony and reverse triggering. Those are the two different ones. I'm not sure whether there are any questions. Yes, there are. I know we didn't leave a lot of time, maybe one.
Sure.
Okay.
Thank you so much, Eric. This has been really great. We do have a really great question from one of our attendees. They ask, when discussing flow asynchrony, you mentioned changing the inspiratory flow or inspiratory time. Have you considered changing from volume control to pressure-limited ventilation, which would allow the patient to determine their own flow on a per-breath basis?
Absolutely. So I think as you consider everything and all the changes and how we can kind of organize this, I presented how to correct this in the mode that you're living in and operating in, essentially. If the patient has widely variable flow, clearly using VCAC where the flow is limited may not be advantageous, and so then you have to contemplate switching over to a pressure-limited mode where the flow is variable. However, I will say this, is that although that can be a really good alternative, just switching to a variable flow, pressure-limited ventilation, that in and of itself doesn't fix the problem. So you have to still make sure that you have enough flow being delivered based on the pressure gradient to the patient. Meaning, can you still have inadequate flow or inadequate pressure on pressure-limited ventilation? And I'll just ask this question. Can your patient suck frosties, pull really hard, even on pressure-limited ventilation? And I think that answer is yes. And so in that, it's not just the change in mode. It would be a change in mode and recognizing and making sure that there's adequate inspiratory pressure and inspiratory flow. That is a whole nother presentation, how to recognize and correct this asynchrony in pressure-limited ventilation. So I didn't go there in this, but definitely a viable alternative, as is the volume-targeted modes. However, the same issue would happen in then. It's not just the change in mode that fixes the patient. It is allowing for adequate inspiratory flow.
Wonderful. Thank you so much, Eric. I am so happy that you were able to share your expertise with us today.
My pleasure. My pleasure.
And thanks to everyone who attended. The Respiratory Care Journalcast series will kick off in 2020 on Friday, January 17th, with the January Editor's Choice focused on COPD care bundles with presenter Cheryl Herr. And join us also on Thursday, January 30 for an exploration of social determinants of health with Joel Brown. Thank you again for joining us. Have a wonderful holiday season and a safe new year.
All right, I believe that's all the time we have for today. Thank you to our speakers for sharing their expertise, and thanks to our participants for joining today. If you are a group participant, please have your group leader submit your information to the Group Attendance tab to be provided with follow-up instructions on how to submit for credit. This concludes today's presentation. To submit for credit, please click on the Credit Submission tab. Once finished, you may simply exit out of the browser window. We hope you have a great afternoon.